So this is me. Oh, you can't see some of it, but I was very generously introduced. And not only did I practice emergency medicine for 10 years, but I practiced as a locum tenens doctor. And I've worked in about 15 different health systems, including here. I worked at CPMC, in the Mission, and in the Davies campus in the Castro. And I also am an investor. I started real estate investing in my early 20s. And in 2012, a friend of mine told me about Bitcoin, and I was looking at it, and then I watched it tumble, and I said, well, I'm glad I didn't invest in that. And then 2015, when I was actually here in Silicon Valley, I started learning about it more because more people were talking about it, and I started investing and understanding how the technology worked. At the same time, one of the hospitals that I had worked for was using my provider identity, my Medicare and Medicaid PTAN numbers, to build charts on patients when I was no longer working there. So that's Medicare and Medicaid fraud, right? So it was a situation of identity theft that occurred, and it was because of the employment process and the credentialing process, and the fact that we as physicians really kind of give the health systems all of our information, and it's not really secure. And so when that happened, I realized that this technology could potentially have prevented what happened to me, but then the more I thought about it, the more I realized that it could actually be applied to a lot of the problems that plague our current healthcare system. So that's what made me kind of start this. So this is one of the two big problems that we're going to talk about, the physician shortage. So we're looking at a shortage of 42 to 121 plus thousand doctors by 2030. The shortage is due to a lot of things. Sustainable growth rate is frozen, so we don't have enough funding for graduate medical education in this country. Physicians are leaving medicine early, retiring early, leaving and pursuing entrepreneurial endeavors. And the physician suicide rate is actually the #1 suicide rate of any profession. It used to be dentists, now it's physicians. So there's a lot of reasons there's a shortage coming up.
Is that more than police officers and ambulance care?
Yes.
People as well?
Yes.
Wow.
Mm-hmm. Only over the past 3 or 4 years they started noticing that trend. And it has a lot to do with the HITECH Act. All of a sudden we have all these administrative burdens and all of these new things that are required of us, yet we're not given any extra time or any extra resources. So we become data entry clerks. So this is the other problem, the cost of healthcare. This is the thing that we keep hearing about. $3.9 trillion, that's a lot of money. And it's actually the 5th biggest economy in the world. So we have the US entire economy, then we have China, then we have Japan, then we have Germany, and then we have the US healthcare system is bigger than every other country's entire economy. And so just, does anybody know who controls that money? Who's the one that determines where that money's spent? Anyone?
Mostly government, I'm sure.
Government, maybe. Insurance companies. Anyone else? Employers.
Physicians.
Well, so I would argue that it's physicians, because without the stroke of a doctor's pen, nothing happens. You don't get a CAT scan, you don't get a prescription, you don't get surgery, you don't get a hospital stay. It's really the doctor's decision where that money goes and where it flows. And so because of that, health systems have started gobbling up physicians' practices, and we've seen an increase in physician employment. And so, and if you look at this, almost 30% of this money is wasted unnecessarily. A lot of administrative waste. And in my opinion, credentialing should be part of that waste. It's a long 2 to 3 month process, lots of administrative waste on both ends, the doctor and the patient. So. And so this is, it says our new healthcare system, but this is really our current healthcare system. And if you look at it, the Secretary of Health and Human Services is at the center. It looks like a huge mess, very complicated. And where's the doctor? You go ahead. Click. There's the doctor in the corner, and then where's the patient? There it is. So, kind of on the outskirts, not really that important. So if you look at this potentially better system where the doctor and the patient are in the middle, but I think it could get even better, where we have a future system that's a decentralized system. Where there's still a doctor and a patient, still people interacting with each other, We're always going to have enterprise systems. We're going to have EHR companies. We're going to have insurance. We're going to have government. And so in the future system, each entity will have an identity, self-sovereign identity, which will allow them to interact in a digital space. And the digital identities will be able to hold digital assets. So our credentials as physicians are one of them. Digital assets can also be digital money, like cryptocurrency, titles to cars, homes, communications tools. So this is a future that we see. So self-sovereign identity. So I just want to talk briefly, I'm going to spend a second on this slide. It sounds like a lot of people in this room know blockchain and understand it, so I'm not going to spend too much time on that. But 1991 is when the internet and the World Wide Web was kind of deployed into society. And then it took like 2 years for Silicon Valley to start adopting it and developing new software tools around it. But blockchain solves a lot of the problems that the internet can't solve. And it's really 5 main things. And self-sovereignty is one of them, where you as an individual own and control your own data. And the next one is immutability. And that's actually the most important piece, because without the immutability, you don't have a blockchain. And it's not only immutability, it's the fact that it's copied on thousands of computers at the same time that it's immutable. So instead of one copy of one ledger that the bank has on their servers, and maybe they have it in the cloud and they have their servers all over the place to make sure that they don't lose that one copy, they're still in control of that copy. In a decentralized system, we're going a little bit fast. It's okay. It's okay. But in a decentralized system, you can't cook the books if you can't make a transaction unless the previous transaction also matches those thousands of computers. So that if you have somebody who says that they want to cross it out and say that they gave you $10,000 instead of $5,000, it won't be allowed because it won't match the copies. So it's the immutability that creates the ability for all these other values that come from the blockchain. And so it creates trust, essentially, allowing people to trust that they, who they're dealing with. Transparency and provenance. Dr. Rao talked about this a little bit, about knowing that the person that you're transacting with is not only who they say they are, but have what they say they have, and are allowed to do that transaction. That's something that you need a third party in the current internet situation. And then disintermediation. If you no longer need a third party to build that trust, to guarantee the provenance of the data or the information, then you no longer need third parties, so it disintermediates the need for that entity. So why is this applicable to healthcare? So we still have the physician and the patient, and they're still interacting, but if the physician has a self-sovereign identity that they own and they control their credentials. It's no longer the hospital that's deciding when to bill Medicare and Medicaid, it's the individual physician. Then we kind of reduce all the waste that's associated with the credentialing process, that 2 to 3 months can now be reduced to moments, preferably. It improves employment mobility. So right now, if you're employed by a health system and you want a new job and you have to wait 3 months before you're allowed to work, it kind of it prevents you from wanting to apply for new jobs. It prevents you from wanting to move. If the hospital down the street needs me, I'm licensed in California, I'm here for a week on vacation. If I want to pick up a shift, make a few bucks, I can't. So this type of system might allow for something like that. It'll allow you to be paid at the time of service, because the transparency and provenance that's afforded in a system like this will allow you to be able to say what you charge and what you should be paid, and you can get paid immediately. This will reduce administrative waste, not only for you, but for health systems, for insurance companies. And then the decentralized communications tools will allow for secure communication with patients, and it can allow secure communication with your fellow colleagues so that you can curbside consult individuals, knowing you're talking to who you're talking to, knowing their credentials, and you can make this secure. So for patients, of course, we've all heard about the electronic record. If you have a self-sovereign identity and you own your electronic record, that can also be portable between health systems. You'll no longer be trapped in a certain health system when you want to get surgery in another system or you want to see a doctor in another system. You can take that data with you because you own it. You can choose your caregivers looking on the decentralized database. So right now we have, ZocDoc or Doctor.com or Yelp or just word of mouth or whoever your personal doctor tells you should see. Imagine if you had a decentralized database of physicians. You can see how long they've been practicing, what their credentials are, where they're located, how many of this type of procedure they've done, how many of this type of procedure they've done. Perhaps even data around their outcomes might be shared because it would improve their likelihood to attract more patients. So this will also reduce administrative paperwork for patients. A lot of people spend a lot of time on the phone trying to figure out why they're paying what and why their insurance isn't covering the thing that they thought it was going to cover. So that'll go away as well. It'll allow them to communicate with their physicians directly also. Being able to follow your doctor. Right now, if you leave a health system, you can't take your patients with you unless it's a health system that you were a partial owner in. I have so many physician colleagues who lost their patient base when they were terminated. That's a problem because those patients wanted to follow them. And then improved access to the right kind of doctor for the right kind of service. Knowing who's doing what, know how long that they've been in practice and things like that. And of course, enterprise and government will still exist and they'll still interact with the system, but it'll be in new ways. So is government on board with this? So this is just my way of hinting that if and when we design a system like this, it's going to be allowed because there's certain things that have come through the pipeline in the last couple of years from a legislative standpoint that are showing that the government is on board with people owning their data. GDPR in the UK and in all of Europe is one other example. So we'll still have enterprise and government, and the ONC is part of HSS, which is the entity that was in the middle of that very, very messy slide that I first showed you. And so if you look at the bottom, it says, we use our levers to accelerate individuals' ability to access and send their health information so they can shop for and coordinate care. And that's part of the 21st Century Cures Act, where they recently put out some legislation saying that they're going to be enforcing interoperability and they're going to be reducing and penalizing information blocking. So if anybody knows the EHR systems that currently exist, they're not interoperable at all and they block information for everybody. So right now they're faced with having these very expensive systems that they put a lot of energy into building that are really useless to us. They're useless to physicians. We've been saying this for years. They're useless to patients. Patients can't get their data. So now they're either going to be faced with completely redesigning their systems or I don't know what else, being replaced, I guess. So, and then this is just some information from the website. If you want to keep going, you can go again. And if you want more information, that's there. So what's going to happen to the old system? They're still going to exist. You can go ahead. You can go ahead, yeah. So the electronic health records companies, they're either going to need to design a whole new system or they're going to need to comply with the new systems that are coming about, the self-sovereign systems that are owned by the doctors and by the patients and by other models that are actually providing a value. So third-party administrators, Dr. Rao mentioned the drug shortage issue, but nobody mentioned the pharmacy benefit manager situation. And, there are third-party administrators that essentially control the supply chain of drugs. So he mentioned the normal saline shortage. Why is it that we're out of salt water? I can make salt water in my basement. Like I took chemistry. I have a background in biochemistry. Why is it that something that we use to resuscitate people from the dead and that we use on the majority of patients in the hospital, why is there only one place that makes that? Well, it's because the cost to get those things into the hospital supply chain is so high because there's something called rebates that are really kickbacks that these pharmacy benefit managers have. So they're third-party administrators that were designed, and implemented a long time ago in order to keep things safe, but really it's an antiquated system that's now only costing the system so much money that new manufacturers, it's not even worth it to make new things. Same things with the device industry, the GPO issue. So third-party administrators, I think, will fall away, or they'll find a way to repurpose themselves. Pharmaceutical companies, same thing with the pharmaceutical supply chain. Insurance companies, are they going to go away? Absolutely not. I think that we're going to have high deductible health plans, but they're going to have to be more transparent with their prices, and they're going to have to be more clear about what's covered when, so that there's no more surprise bills. And then hospitals and health systems are, of course, also going to need to adapt to this new system. And so government, when you talk about physician data and provider data, we have the Federal State Medical Licensing Board, the National Practitioners Database, the National Board of Medical Examiners, and CAQH right now that work on physician credentialing. And they're essentially data silos also. Why is it that I, as a physician, I have my medical degree on my wall, my residency certificate on my wall, my state licenses in my file cabinet, why do they all have their copies of things, and why are they also regulating? In some ways, they're third parties. Will we still need them? Sure, but their roles are going to change in this new system. So the Department of Health and Human Services will obviously still exist. They seem to be on board with a new system like this when I look at some of the laws and the regulations that have been recently put forth. CMS, same thing. They're still going to exist, obviously. And then the value-based care. We're hearing all this value-based care stuff, the MIPS, the MACRA, the meaningless use, because really there's no way to measure these things. And the more new ways they try to learn to measure what physicians are doing and what's valuable and what's not, the more they're realizing that it's not measurable, at least not in the ways that they're trying to measure it. So I think that these types of systems are going to fall away. And then, of course, standards. In order to create systems that are interoperable, you need standards. So I think that we're going to be paying more attention to those kinds of things as well. So a little bit about what we're working on. So we're working on self-sovereign identity and credentialing solutions for physicians, allowing physicians to have ownership of their professional brand in a digital space. And so this will reduce administrative costs to all parties, eliminate the redundant validation and authentication that comes with this laborious old way of credentialing. It's going to help physicians, insurers, and health systems. And then it will also, so that's the identity piece. The other part is the organization, the Digital Physicians Guild that will essentially be created with a system where the physician workforce will be able to organize, collaborate, communicate, convene around policy and practice, where they'll be able to share data that they're generating through their electronic health record systems. It'll streamline the hiring process. It'll allow for employment mobility. It'll improve the physician shortage problem. The data will now be clean because we'll have provenance around it. We'll know where it's coming from. It won't be this dirty conglomerate of people just clicking the box to get to the next thing. We'll actually have real information because it'll be self-sovereign information. And then it'll allow for anonymous sharing, so nobody's being punished for not doing something. They're just sharing so that we can learn more. And so this is the proposed platform. So we'll have patients and other payers still. We'll still have physicians, but they'll have their ability to move and interact kept in a self-sovereign wallet that they own and they control, not a third party, not a health system, not an insurer or a credentialing system. And so transactional fee, we propose 2% based on the financial model that we're looking at, and that will go to power the network. We'll allow for the peer-to-peer payment system, credentialing, and data analytics. And then the rest will go to investors as well as the community. And the community is really, in my opinion, the most important and the most valuable part of this. It'll allow people, if they're on the other side of the country or on the other side of the world, instead of having a case report that you need to submit to a journal article, hope that it publishes, you now can find other physicians who have similar case reports and pull your data together and find out meaningful information in a quicker and a more streamlined way.
5 minutes.
Okay, wow, I went faster than I thought. You can keep going. So this will allow for governance, voting, and democracy for the physician community. So we can decide, okay, there's this new practice guideline. Is pain really the 5th vital sign, or do we not agree with that? And we can talk about that, and we can decide whether or not we think it's safe for patients to move forward with these things. We can publish a consumer reports of all things healthcare. Imagine if a new device comes onto the market and the first 10,000 orthopedic surgeons who use it get to rate it and say how their outcomes were. And they're able to publish that data directly without any special interest influencing whether or not it gets published. I think that would be very valuable to the patient population. Grant funding and idea incubation. Right now, if you work for Stanford and you come up with a new idea, they own the idea. You signed a contract, you signed a mafia contract in the beginning of your employment there where they own the idea unless there was some other arrangement that you decided to make. But that's your intellectual property. So this type of system will allow you to incubate your ideas in a decentralized way. It'll reward people for contributions either through research or legislative processes. And then advertising services. Right now there's certain advertising organizations who initially had a free service. And then once they got everybody on board, they started charging them a little bit. And then they just started charging more. And now there's a new thing that they're going to charge you. Well, that's because they're a third party. So if we have a decentralized physician database, we no longer need advertising services because we can, in a self-sovereign way, advertise our own services. So there's lots more potential applications to a system like this, and so this is what we're working on building. And so the way that people will be able to get these services are through tokens that they get after utilizing the platform, and then they can trade those tokens for those services. And that's just the proposed platform. This is something we're talking to development firms about. And I didn't bring up my team. I do have a team also. I have a top securities attorney in New York City, Paul Goodman, who's working with me, he knows how to code. He's launched multiple blockchain companies. I have Dr. Alex Kahana, who is very well known in the space. He's flown internationally to speak about blockchain in healthcare. He's an anesthesiologist who also was a top pain management specialist at WashU at one point. And he's also a doctor. He's a doctor of philosophy as well as an MD. And I have a business development person named Yasmin Drummond who's been helping me a lot as well. So that's it. Please connect with me on Twitter and social media. And thank you.
Questions?
Awesome.
So I have a question about the 2% fee. Is that a self-subscribed fee that people would, a transaction fee, or this is not a national tax? I mean, I can imagine that you could have a national tax at a much smaller amount and really put this patient at the center of all of this in terms of owning this and creating a blockchain that brings the enterprise and the government and the patient and the physician in, that this wouldn't have to be just funded by physicians. So I'm just wondering, have you thought about addressing some type of very small tax to really roll this out?
Well, I'm not closed to anything at this point, but that's a 2% transactional fee not paid by the doctors. It's automatically going to be cryptographically encoded into the platform. So if you receive any type of payment on the platform, then it automatically will take a 2% transactional fee. Like if you're a member of a union dues are around 3 to 5%, and you're forced to have that taken. In this system, you're not forced because you don't have to use the platform, but if you do use it, you get the transactional fee taken, but then you also get to have all those services that come along with it that I think physicians will find very valuable. People talked about a membership model. I think physicians and patients aren't interested in doing that. So I think just having people only be charged if they're using it and if they're finding value is a smarter way to do it. Yes. Oh.
Do you see the patient blockchain model where they own their own data interacting directly with
Yeah, so there's lots of self-sovereign health records platforms being built. My personal favorite is HIE of One. Dr. Adrian Gropper is also a physician, and he's building a self-sovereign model on the UPort system. So yes, the patients will have their own identities, they will be self-sovereign. Doctors will have their own identities, they will be self-sovereign. The record will be something that they create together. The patient owns the data, but the physician also created that data, so we have access to that as well. And so, I'm not focused on the patient solution. If we build this and the patient solutions that are out there are not good, then we're going to try to help build the right kind of solution for patients also. But I'm hoping that somebody else does it, because in order for something to be truly self-sovereign, they need to have a right to choose the one that works for them. So, yes.
How far are you with the system? Do you already have your token out, or is there white paper?
So yeah, I have a white paper that I don't have on the website because we're not doing a cryptocurrency. He was asking if we have a white paper, but self-sovereign identity platforms are already out there and being built. Actually, they're already built. I'm going to be back here in about a week and a half for the World Identity Conference, where all the people who are building self-sovereign identity platforms are going to be here. There's a self-sovereign physician credentialing and identity tool that's being used in the UK. It's called TrueID, TRUU.ID, where physician Dr. Mani Najjar has built it. So he and I have been talking for a while now. And so that system exists for the UK, but the UK credentialing and training and practice tools are very different than the US. But he's willing to potentially white label that technology and let us use it here to demonstrate a use case. And then we can build something really robust and bespoke for our needs.
So how do you plan to enter a market? Is there a use case? This is a huge ecosystem.
So by the fact that it's already existing and that it's already being used in the UK, the NHS system is using something similar to this just for the credentialing and the identity portion. So it already exists. It's already being adopted in the UK. It's not in the US yet.
But it's
So,
not on the blockchain, is it?
I'm sorry, what?
Is it on the blockchain?
It is, yes, and it's self-sovereign. So, 2 weeks ago, for example, I met with Columbia University, COO, and I talked to them about demonstrating a use case there. They have medical students, they have residents, they have attendings. We're going to demonstrate the supply chain, then we're going to go to the New York State Medical Licensing Board. And once every player says, yes, we agree that this is validating and appropriately authenticating each physician, then we can go to the next school and the next state. So that's the stage that we're at now.
How easy it is to get that kind of personal data? If the data belongs to the patient and the physician, let's say you go to the hospital, how do they get that data? Do you have to be released by the patient, or just?
Well, so who creates the record? So she was asking, how do we get the data? So who creates the health record?
The doctors.
The doctors.
Right.
So if we build a new system where the records that we're creating are our records that we then give to the patient because they're also the patient's records, then we're disintermediating the need for an electronic health record system that's a proprietary system owned by the hospital. And people are all talking about, well, you need to work with the hospitals and you need to work with current EHR companies. Well, physicians and patients agree that those systems aren't good, that they're not providing valuable data, that the data is dirty, it's not able to be, in some ways it's interesting to look at data analytics around it, but when you talk about the actual value to the individual person, it's not valuable. So we're creating the new system.
Is there any consistency in terms of how the doctor will be entering the data? Because it can vary from doctor to doctor, what sounds like with the system.
Well, that's why you need things that are built on standards, So right now, every single self-sovereign platform that's being built, they're really paying close attention to standards, and that's why they're having these conferences where they all come together and say, okay, we're each building our own way of doing things, but we're going to make sure that these basic characteristics exist so that if a patient wants to transfer their data to a new system because they don't like that system, it's easy. So if you're building a system for a self-sovereign model, you want to make sure that it's based on those standards so that people have true self-sovereignty, ownership over their ability to move and transport their data to another system if they don't like it. One more, okay, lots more.
I'm struggling with the physician creates the data because, as you know, maybe the radiologist creates part of it, pathologist creates part of it, the attending creates part of it, but no one is necessarily in control of all the data. And then you do have the healthcare institutions would bring the wrath of God if someone tried to say, you know what, I created this data, so I'm going to take it with me, and because it just seems like that I get the value of it. It just doesn't seem like that would be very possible, especially since no physician created the entire patient record.
No, I totally agree. But for example, if you are an individual and you have your primary care doctor, those records are very valuable. If we create a system that's based on standards that are interoperable with all other systems based on what the 21st Century Cures Act is requiring and based on what GDPR is requiring of society, then those systems will easily be able to integrate and be portable for the patient to take with them. And I agree, health systems aren't going to love it, EHR companies aren't going to love it, but this is what people are demanding, so.
I'm cheering you on.
Thank you.
Struggling.
Yeah, it's a big jump. This is very on the edge of reality because our current reality is in a proprietary system where, somebody's hoarding everything and you can't get any of it. Well, we don't like that system. Yes?
Yeah, and by the way, I like the premise behind everything as well. Credentialing, how much, it sounds like you spent a lot of time figuring out where to start, and I like the idea that credentialing seems like something that is okay to kind of be public, and a physician clearly owns their own credentials, right? Less kind of, they own their own credentials. So when it comes to just the credentialing piece, can you talk about like the potential revenue or like payment purchases that might happen with that? One could be like the health system or a state that does credentialing. I'm not as familiar with the process, but just around that specific use case.
Right, so the credentialing process, even if you're working in a health system, you have to do it every 2 years. So one of the doctors I talked to, he was working in the same health system from the day he graduated from residency, and every single 2 years he had to validate that he went to this medical school, and they had to call the medical school. And one day the school that he went to medical school in closed. And he wasn't able to work for like 3 months because the health system that he worked for like 20 years wasn't able to validate the medical school that he went to, even though he had worked there for 20 years. It's such an antiquated, backwards process. And so, right now it costs health systems around, from what I gather, there's no real number out there, about $3,000 per physician or provider every 2 years. And then it takes 10 hours of my uncompensated time. So that's like another $2,000 to $3,000, depending on how much you get paid per hour. So it's, a $5,000 to $6,000 process per physician per 2 years. That's the current cost, and that doesn't include the opportunity cost of mistakes, redundancies, things like that. So, being able to validate that you went to medical school once in your life, spending that time and energy to do that, and then never having to do it again, super valuable to me anyway. So,
Again, because things change.
Well, you went to medical school once.
No, but the additional information about changes in your practice or malpractice.
Right, I'm not saying that we're not going to need to update other things. So, for example, your medical license, there's going to be, an expiration date on that. You need to show that you renewed that. But certain things you don't have to be redundant over. And then those types of things, if this, the state medical licensing department has an identity where you can, ping, this is going to be expiring in 4 weeks, put in the request, have them validate that you did the things you needed to do, and instead of faxing, overnighting, mailing, nonsense, it can be done electronically.
So, quick follow-up on that.
Yes.
So it sounds like every state has their own credentialing kind of system right now, or you get credentialed each
Every health system has its own credentialing system. So some of them I had to pee in a cup. Some of them I didn't. Some of them I had to go in and like do this weird test with like a, you know, a thing for PPD, and it was like another one I had to do like a full physical exam. They take my blood. Every system's different, you know? So I'm not saying that we're gonna force hospitals to accept whatever we choose. I'm saying that the things that don't need to be repeated, the things that are taking a lot of our time and energy, we can streamline those. We can say, hey, like of every single health system, every single insurance company, these 30 things are required by 90% of them, so we're going to include those in our system, and anything extra, I'm not saying we're going to strong arm systems into only taking our credentialing. I'm just saying we're going to make it easier for both the doctor and the patient and the system, you know.
Okay, last question.
Okay.
Well, this was just a small comment that I saw in the news today, that the state of Arizona, I don't know if you saw this, but they've decided to recognize licenses for anybody who's working in trucking or cosmetology or physicians, that you can come to Arizona and have your license be active immediately, you don't have to work. And they didn't say how that was going to work, and I was wondering if it was blockchain de-identification. I'm not sure, but it was a way, I guess, of bringing in workers and ways to attract people. But there must be some type of influence about what you're talking about, what they're doing in Arizona. And it was just today, yeah.
Actually, a couple of days ago. It's increased business basically. It's like, you know what, no more barriers to entry. Someone who actually just has a license from the state, in theory, could just come there and probably just show the license, and boom, you're done. You're allowed to practice.
So the question was around interstate license reciprocity for other types of licenses, cosmetology, truck driving, things like that. And there is an interstate medical licensing compact that the Federal State Medical Licensing Board is working towards implementing, where you'll be able to take your license across borders. The problem, and I thought, wow, that's great when I first heard about it, because it sounds like a great idea. Oh my gosh, like I have 3 licenses, Florida, California, New York. It's a pain in the butt to renew those licenses every year. Lots of uncompensated time, lots of administrative burden. However, this compact is requiring mock. And I don't know if you guys know, but the American Board of Internal Medicine is being sued for potential racketeering claims and restraint of trade claims. So Practicing Physicians of America is getting together some funding to kind of investigate this, because for people who got board certified 15, 20 years ago, they have lifetime boards. But for me, I have to do mock every 2 years, and it costs lots of money, lots of time, and it's not acceptable to me. And it's not acceptable to them. So if you're now going to require mock, which is a private organization, it's not a federal organization, it's not government. So essentially, the government has allowed this private organization to impose new tests, new guidelines on us. Hospitals, health systems, insurance companies force us to do mock. It's a restraint of trade. So I'm against the Interstate Medical Licensing Compact, but I do think once a system like this is built, we can potentially implement tools that allow for interstate license reciprocity if states want to do that, as long as it's the decision of the individual physician and not some, third-party overlord.
All right, thank you very much.